Okay, this is the last review that I'm going to do for the final exam in pharmacology. Uh, and on this one, we're going to cover the alpha drugs, both the agonist and the antagonist and the beta blockers. So we did the beta 2 agonists in the last section. So beginning with the alpha 1 agonists, these are drugs that you'll encounter predominantly in the fact for the fact that they're nasal decongestants, and to some extent they are over-the-counter diet aids. And these drugs are characterized by the property of tachyphylaxis, which you now know. Some of the drugs include pseudoephedrine and phenylephrine and many others as well. And formerly the drug phenylpropanolamine, which is abbreviated PPA, and I include this because this was an interesting drug. It was used widespread use over the counter for a long time, and then it was discovered that it caused in some individuals some heart difficulties, some cardiovascular problems, and the FDA issued a voluntary recall and just asked pharmacists if you would take this off the shelf, and they did. And the drug went away except for it retained a veterinary use. So all of these drugs are relatively short acting in the first bullet point because they are subject to fairly rapid metabolism by monoamine oxidase and catecholomethyltransferase. In some preparations, products, you'll see that they're listed as being long acting, and those products will contain an active ingredient like oxymetazoline, which is in the Afrin or other versions of the 12-hour nose sprays, and it's resistant to destruction by those enzymes and hence lasts a long time. There are a number of drugs that have been used as alpha agonists to treat hypotensive states in the past, and these are a kind of becoming lost to history, but I mention them and others because they may come back, and it just generally presents the idea of what it is that alpha 1 agonists do. So methoxamine was one that was used as a vasoconstrictor. Mephentermine was another one, not in clinical use now. This is an example of a drug that has mixed mechanisms of actions that we saw in the previous lecture. Then that it acts as both a postsynaptic agonist and stimulates norepinephrine release. So therefore, it's got a dual mechanism of action. And it was used to treat hypotension, and it's a cardiac stimulant because it releases norepinephrine on cardiac neurons. This one is worth noting because it's abusable and it's addictive performance enhancer. So it's still available. You can probably find this somewhere on the internet and order it, and it has been abused by some competitive athletes. And I pointed out its structure. It is one methyl group different from methamphetamine. All right. And this was, I thought, an important feature that was interesting to me, that some of these drugs as alpha agonists can treat the hypotension or very low blood pressure that can be a problem with general anesthesia in the elderly population, which causes a condition called postoperative cognitive dysfunction. And you see this when an elderly person breaks a hip, a 92-year-old falls and breaks a hip, and then they have surgery to do the hip replacement, and the hip heals, but they never get over the anesthetic effects that they encountered in the surgery. So a couple of others in this class, metaraminol, which has been discontinued. It also has two mechanisms of action. It's a vasoconstrictor. And I included this third bullet point right here because this is an interesting phenomenon that allows you to integrate some of the information that we've learned earlier. This drug was used to treat paroxysmal supraventricular tachycardia, that is sudden rapid heart rate where the origin was somewhere above the ventricles, and it treats that, it slows the heart down. Why would an alpha agonist do that? And the answer is because it causes vasoconstriction, which increases blood pressure, which activates the baroreceptors, which sends parasympathetic signals to the heart to slow the heart. So it's just a kind of a clever pathway there that I thought was worth your knowing in a pharmacology class. Midodrine was another, and I only mentioned it to keep alive the idea of prodrugs, and to emphasize that these drugs may be used, alpha agonists in general, may be used to treat autonomic insufficiency, which would cause postural hypotension or orthostatic hypotension, the phenomenon of feeling faint when you stand up after having been lying down or sitting down, which, again, a particular problem in the elderly. Norepinephrine is often listed as an alpha-1 agonist. It's an untreatable drug, and it's used to treat shock states. And I mentioned different types of shock, where shock is a general term meaning low blood pressure. But it's not frequently used because it has some cardiovascular dangers. Historically, alpha-1 agonists have been used as over-the-counter weight loss products. And here's some of them that have, amphetamine, which is, I think, an active ingredient in Adderall. Others, dexamphetamine, benzamphetamine, methamphetamine, all of these are alpha agonists that would cause loss of appetite. Phentermine, which was used in combination with topiramate, which you'll learn more about in Dr. Pond's pharmacology class. The product is Qsymia, and previously there was a famous product called Fen-Phen, which was phentermine and fenfluramine, which was a big, huge hit for weight loss, worked really well, but it caused pulmonary hypertension, which could be fatal in a large portion of the patient population. So it got jerked from the market along with billions of dollars in lawsuits. And here's some others, and just recognize these as alpha agonists that have been used for weight loss. Phenylpropanolamine, this is the one that pharmacists were asked to voluntarily take off the shelf, and they did. And I found it humorous that this used to be in the 70s and early 80s, this was a widely advertised on television weight loss product called AIDS. And, obviously with the emergence of AIDS as a disease, right, acquired immune deficiency syndrome, this product died. So I was kind of amused by that. I thought this was interesting physiology for weight loss products. I know this is a little bit of a tangent off of our main topic here, but at one point this compound, and one point I mean in the 1930s, this drug 2,4-dinitrophenol was used for weight loss, and it worked. And its mechanism of action is that it uncouples oxidative phosphorylation, and that you will recall from biochemistry, you need that proton gradient across the inner mitochondrial membrane. And those protons, when they move across the membrane, if they're coupled to ATP synthase, they'll cause that. That's an enzyme that converts ADP to ATP. And so the electron transport, as they're moving down the chain, generate ATP. Well, this drug disrupted the proton gradient. It essentially binds the protons, and it's really lipophilic, and it just pulled them across the gradient. So you lost the ability to generate ATP, but you don't lose the ability to transfer electrons down the chain, which is a way of expending calories. And so it was a clever mechanism for producing weight loss, because you burn up calories as heat, which you don't have to do anything to burn calories. You just sit around and take the drug. And it worked, but this drug caused cataracts, and it didn't progress. But we've subsequently found that they're naturally occurring proteins that will do essentially the same thing, and they're called uncoupling proteins. And I mentioned these previously with relationship to beta-3 receptor activation in fat tissue. These proteins will start to be synthesized, and they do uncouple this proton gradient from synthesizing ATP and allow the electrons to travel down the electron transport chain and you know, burn up calories by generating heat, and this becomes a potential drug target in the future. Um, and believe me when I tell you that there are serious labs out there that are actively investigating the uncoupling proteins as a mechanism for weight loss. And any drug that is discovered that effectively produces weight loss over a long period of time is going to be one of the biggest drugs on the market. It will be the equivalent of the new Viagra. All right, so that's all alpha 1 agonists, right, that are mostly stimulatory and hype people up and raise blood pressure and reduce appetite and cause nasal decongestion. And now we're looking at alpha 2 agonists, and the alpha 2 receptors produce essentially opposing effects. So there's multiple different types of alpha 2 receptors here. I want to ask detailed questions about that. And they have this mechanism of action that's related to inhibition using a G protein coupled mechanisms. And mostly they're known for their ability to block calcium channels. And the collective effects of all these mechanisms of actions of these drugs is that they inhibit norepinephrine release, which is going to be like an anti-sympathetic effect. And they're associated with a reduction in blood pressure and a slower heartbeat. And originally it was thought that this was a peripheral presynaptic effect, but no, it's one that occurs in the brain that we found out later. They have been more useful for producing sedation and analgesia, and they're actively used in drug withdrawal because they mitigate the negative effects of drug withdrawal. And I mentioned the locus coeruleus here, and that is Latin for blue place. This is blue, this is spot, right, or locus place. And I put this little figure down in here to show you essentially where it is, right, in the brainstem. And it's a center that when it's activated or stimulated, it causes a general sense of arousal, awareness. You know, you get kind of hyped up, wakefulness, alertness, vigilance. All that comes out of the locus coeruleus, and alpha 2 mechanisms inhibit that. So they calm people down and lower blood pressure from their actions in the brain. So here's just a little recap of the presynaptic effect. So this would be a noradrenergic neuron right here that's releasing norepinephrine, and some of that norepinephrine is going to feed back onto the presynaptic alpha 2 receptor right there. And when the alpha 2 receptor is activated, the G protein mechanism is invoked, and it goes over, and I got to figure out how to make that stop popping up. Pause while I sort this out. So the presynaptic effect is to reduce, as you see, lots of little dots over here, right? And when the alpha 2 receptor has been activated, you see many fewer dots over here on the right-hand side. And that's because the presynaptic alpha 2 receptor is inhibiting the calcium influx, and calcium influx is necessary for the synaptic vesicles to fuse with the presynaptic membrane and release the neurotransmitter. So that's essentially the mechanism of action of alpha 2 receptors. And I wanted to talk just briefly about this descending inhibition phenomenon that occurs to produce analgesia. It also produces descending inhibition is involved in a lot of different pathways having to do with perception of pain and control of muscles. So here's an example of the presynaptic pathway very quickly. A pain receptor is activated. You drop a hammer on your toe, so pain neurons fire, and that primary pain afferent neuron comes into the spinal cord and makes a synapse in an area of the spinal cord called the substantia gelatinosa, and carries the signal on up towards the brain, where it ultimately reaches your consciousness and you experience the phenomenon of ouch. And there are pathways in your brain where they send signals in the opposite direction, in a descending, going down the spinal cord, where ultimately a neurotransmitter is released at this presynaptic location right here to inhibit the neurotransmitter that's coming out of the primary afferent neuron. So it weakens this signaling pathway that's carrying the pain signal up. And so this is presynaptic inhibition in the in the spinal cord, in the substantia gelatinosa that limits pain signaling. So, which can be useful. And this is invoked. This descending inhibition will be invoked in an emergency situation. You know, if you get in a fight or you have to run because you're scared or some other sympathetic condition, and you get injured along the way, and often you don't notice the injury, you don't feel the pain, and that's because the sympathetic nervous system invokes this descending inhibition to stop you from being so conscious of the pain, so you can do whatever it is that you need to do to address the local environment. So here's some of the alpha-2 agonist drugs: clonidine, guanabenzine, and guanfacine. There are several others. And these drugs were, when they were discovered, they were found to lower blood pressure, and for a while they became primary drugs in the treatment of hypertension. Subsequently, we found out that there are better drugs to do this, but they do lower blood pressure. Clonidine has persisted due to its central activity in the treatment of addiction and drug withdrawal, and as used as a pre-anesthetic to cause sedation, which lowers the amount of general anesthesia that's required to make a patient unconscious. And I mentioned down here that they may act partially, their mechanism of action may be attributed to a receptor that we hadn't talked about previously, the imidazoline receptor. I don't know of any drugs that are out there right now that are listed as imidazoline receptor active drugs, but this will probably be coming in the future. I've got an upcoming slide on that. A couple of other alpha-2 agonists, tizanidine or Xanaflex, is an antispasticity drug, and it probably works on that descending pathway to treat diseases of inappropriate muscle contraction. Its mechanism of action is listed as being both an alpha-2 and imidazoline receptor agonist. Could be something else. And I'll put this finer type in here as that there's an interaction between tizanidine and ciprofloxacin, most likely due to inhibition of the CYP1A2 enzyme by ciprofloxacin, which will inhibit the metabolism of tizanidine, which can cause essentially the patient to be overdosed, and can they'll have too much of the drug in their system if the metabolism is inhibited, and this can cause a dangerous hypotension and excessive drowsiness. And I'm just keeping alive the idea and the importance of drug interactions through inhibition of metabolism at cytochrome P450s. A couple of others that we'll hear again later: apraclonidine and brimonidine as anti-glaucomal agents. And then quickly, tetrahydrozoline, which is an over-the-counter active ingredient agonist at the alpha-2 imidazoline or I1 receptor, causing vasoconstriction in the eye. Used to be advertised on TV as Visine, gets the red out, right? And ignore that, and the rest of it as well. Just quickly to let you know that there is some reality to these imidazoline receptors. They're similar in their mechanisms to alpha-2 receptors. They are stimulated by clonidine and do lower blood pressure through their actions in the central nervous system. And apraclonidine is also recognized as an imidazoline drug and an alpha-2 drug as well. And there is an endogenous ligand for the imidazoline receptors, right? And it's agmatine is the endogenous agonist. Here's its structure. It's a decarboxylated arginine, and we've seen decarboxylation, like with DOPA, to produce dopamine as a mechanism of producing biologically active monoamines, and this one is more than a monoamine, obviously. So the last drug this is a representative of the unique mechanism of action known as the false transmitter. The drug is alpha-methyl dopa, right? It's got a brand name, which is Aldomet, right? Aldomet. And it is essentially methylated dopa, all right? And enzymes that are involved in the synthesis of norepinephrine don't recognize the difference between this compound and naturally occurring dopa. So it's a dopa molecule, right? So here's dopa down here, and it's got this extra methyl group on it here on the alpha carbon. This is the alpha. This one over here is the beta. It's got this extra methyl group on it, and the enzymes don't see it as being any different from dopa, so they metabolize it to alpha-methyl norepinephrine and store it in vesicles and so forth. It inhibits competitively dopa decarboxylase, so it's stopping dopa from being made into dopamine at the same time, which is going to lower norepinephrine levels. And it gets stored in vesicles as alpha-methyl norepinephrine, and it's released. When it's released, it preferentially activates alpha-2 receptors, which are going to lower blood pressure, right, and without much effect on the alpha-1 receptor. All right, so let me pause while I go drag up the next PowerPoint. So this is the last slide set for the material that's going to be on the final. And it deals with alpha and beta blockers, also known as sympatholytics, and our progression across all the autonomic drugs. We're at the end, right? So if we look at what do the agonists do, right? We just talked about the agonist, and the alpha-1 agonists are vasoconstrictive, inhibit nasal secretion. They also inhibit the passage of urine, and they have an effect on male reproductive function in stimulating ejaculation. And alpha-2 agonists inhibit parasympathetic activity through presynaptic effects and through actions in the central nervous system. So these are agonists. We're going to talk about what happens when you block these receptors. So it's going to be opposing effects to this, right? So if you block the alpha receptors, you get a reduction. And for alpha-1, you get a reduction in blood pressure. You may have some effect on heart rate that is a little complicated. You're going to cause nasal stuffiness. You're going to have an effect on emptying the bladder, and an effect on muscles in the eye, which are going to activate glaucoma, right? Or actually opposing that. So the first one of the alpha antagonist drugs is phenoxybenzamine. And this is an old drug. It has a slight preference for alpha-1 receptors. It is an irreversible antagonist that essentially destroys the alpha-1 receptors by making a covalent bond to them. It treats the excessive blood pressure you see in pheochromocytoma, and which is a disease where patients have a tumor where they're overproducing norepinephrine and may have extreme blood pressures like 400 over 200, which is life-threatening. It's likely to precipitate a stroke or heart attack or something dangerous. So it's kind of a radical therapy, but it's used to treat patients that have a dire condition. Its adverse effects are going to include can be a profound reflex tachycardia, and any alpha-1 antagonist is going to cause nasal decongestion, have an effect on male reproductive function, have an effect on orthostatic hypotension, effects in the eye. This will be important for patients that have glaucoma. It can cause incontinence, and that is the loss of control over the bladder, and an increase in systolic and diastolic blood pressures, which is often what the intent of the use of the drug is. So here's the second one, another older drug, phentolamine. It is active at blocking both alpha-1 and alpha-2 receptors, also used in the treatment of pheochromocytoma, and it's got similar side effects, except that the reflex tachycardia will be pronounced, and that's because the alpha-2 receptors that provide the feedback inhibition on the noradrenergic neurons at the heart are blocked as well, so you get excessive. There's no way for the heart to monitor how much norepinephrine has been released. So, this is a drug that would cause vasodilation because it's blocking alpha-1 receptors, which is going to activate the baroreceptors, which are going to stimulate the heart to beat faster, and that's going to be unopposed by presynaptic inhibition, so you get a profound reflex tachycardia. They're also going to cause the same general side effects on blocking alpha-1 receptors and nasal decongestion. The headache may be due to excessive vasodilation. Headache, some migraines, for example, are associated with excessive vasodilation in the head and have an effect on male reproductive function and orthostatic hypotension, again, meiosis, and that's eye muscles and urinary incontinence as well. So here's some more specific alpha-1 specific drugs, right, which are going to be preferred because their effects is more precise. And these drugs, prazosin, doxazosin, and terazosin, have all been used as antihypertensive agents in the past because they cause vasodilation, which lowers blood pressure, and they're not used so much anymore because we have better drugs for that. But tamsulosin is still used. Its brand name is Flomax. There's a generic form of this available now, and it treats male benign prostatic benign prostatic hyperplasia, which means the prostate gland grows and it becomes difficult to urinate. And as alpha-1 antagonists, they block the alpha receptor at the base of the bladder, which makes the bladder easier to open and empty. And this drug is in fairly widespread use now. And so these drugs are considered all competitive antagonists that are fairly specific for the alpha-1 receptors. I covered this. I mentioned previously Raynaud's syndrome, which is excessive sympathetic tone, too much sympathetic activity, especially in the extremities, causing cold hands and feet, which can be painful, and mentioned that. And their adverse effects or orthostatic hypotension, right? Because you need the vasoconstriction when you go from lying down to stand up to maintain your blood pressure. They can cause some reflex tachycardia, but not as much as phentolamine because they're only blocking the alpha-1 receptors. Nasal decongestion, headache, again, effect on male reproductive function, meiosis, incontinence, right? Which is they facilitate the emptying of the bladder and may be inappropriate. For example, a patient taking doxazosin may have urinary incontinence if they're don't also have benign prostatic hyperplasia. I hope this is clear. I feel like I'm just y'all stay with me. All right, and so here's just a cartoon example of what I'm talking about with the male. This is male benign prostatic hyperplasia. So here's a normal prostate gland, and here's a prostate gland of a man that's older, and it's gotten enlarged, and the pathway for urine flow, which is right through here, right, becomes impeded. And the idea is it's alpha receptors that keep this sphincter muscle closed. So if we block those alpha receptors, then it's easier for the urine to flow this way. I also mentioned this term that you'll see this in other drugs, especially in the neuropharmacology section, that there are a lot of CNS active drugs that cause this phenomenon called retrograde ejaculation. And what that means is that when a male ejaculates, the sperm comes up from the testes and travels down through the prostate gland this way, right? Comes up and around, right? This is through the vas deferens and comes through this way. And if this pathway going up, right, is open, then the semen will go up into the bladder, and that's called retrograde ejaculation. And at some point you had to learn that. I just taught it to you. For alpha-2 antagonists, there's only one compound that I know of that you might encounter at this point, and it's yohimbine. It's an over-the-counter internet available drug. It is considered an erectogenic, and that is that it stimulates male erection, and it may stimulate libido, which is the desire. And it is, if you think about what happens when you agonize or stimulate alpha-2 receptors, you get lower blood pressure and sedation and all that. You're blocking those receptors, you're going to get the opposing effects a meta-analysis said that the authors said that they were cautiously optimistic that this would be useful for treating ED or erectile dysfunction in men, but giving problems with quality control and quality analysis that you see with a lot of over-the-counter products or internet available products is not recommended. But some patient will ask you about this at some point in your future. There is a beta-2 antagonist, butoxamine, but it doesn't have any clinical use that I know of. So that brings us to the last thing of beta blockers, right? And these have been really clinically important drugs, used as for a long time as the first choice in the treatment of hypertension, but no longer, because again, we know that there's other drugs that produce better outcomes over a long term. The mechanism of action of blocking beta receptors on blood pressure is that they cut off the sympathetic tone that's going to the heart, and that decreases heart rate, causes bradycardia, and reduces the work of the heart. And as a result, we found out that these drugs are useful in the treatment of congestive heart failure, because the failing heart is one that can't do the amount of work that it needs to do. The exact mechanism of why these work to treat congestive heart failure is not as clear as I would like for it to be, but they do produce favorable outcomes in the treatment of congestive heart failure. So it's so odd that when I took pharmacology, 100 years ago, we were told never, never, never give a beta blocker to a patient with congestive heart failure, and today it's the first drug you give to a patient with congestive heart failure. So, change happens. I heard recently that a medical school professor told students that 50% of what we're teaching you is wrong. The problem is we just don't know which 50% it is. So this is a historical example of the truth of that statement. Beta blockers have also been used to treat migraine headaches. They're used in the treatment of glaucoma, and they are very sedative-producing drugs. They have been used, propranolol particularly, which we'll see, has been used in the treatment of situational stress, right? Because when you're in situational stress, you got a lot of anxiety, your sympathetic nervous system is kicked in, and part of that sympathetic response is in your brain and your awareness and your alertness, and some of that's mediated by beta receptors, and if you block the beta receptors, then you don't feel all that sympathetic flow associated with situational stress. Situational stress, I mean, like standing up and giving a speech is the number one cause of situational stress. And so beta blockers will reduce that sensation of stress associated with various situations. And they're used in the treatment of thyrotoxicosis, which is an effect that you see with too much thyroid hormone. Thyroid hormone promotes the synthesis of beta receptors, and so somebody with too many beta receptors is going to be, their sympathetic tone is going to be radically increased, and excessive heart rate, cardiac arrhythmias, etc. Will occur with thyrotoxicosis, and beta blockers can treat that effect. So they've got some adverse effects. If they block the beta-2 receptors, right, remember that we saw with beta-2 agonists were used in the treatment of asthma and chronic obstructive pulmonary disease. And so you're stimulating the beta receptors to treat those diseases. If you block the beta receptors, you're going to make those conditions worse. They decrease exercise tolerance because exercise depends on increased heart work, and these drugs decrease the work of the heart, so they decrease the ability to exercise. And I ask you repeatedly to be mindful of what exercise means to an older person. It doesn't mean, going out and doing, marathons or sprinting. It means, can I still mow the lawn? All right. Sorry. Amused at myself. They cause these central nervous system effects, depression, sluggishness, sleepiness. People feel like, oh, I just can't get up. And they decrease gluconeogenesis, lipolysis, and glycogenolysis. And this is appropriate for patients that have sugar disorders like diabetes. And I'm not asking you to know details of that at this point, but just be aware of a connection between that. Patients that have diabetes often have severe bouts of hypoglycemia. Their blood glucose falls really low, dangerously low, and they become aware of that, right? And people with diabetes know that this is going to happen, and they know that the symptoms are tachycardia, anxiety, and tremor, and all of those are blocked by beta receptors. So a patient taking a beta blocker with diabetes may have excessive falls in blood glucose levels and not be aware of it as they would be if they weren't taking the beta blocker. So it masks these signs of hypoglycemia, which is an important feature. So general adverse effects include hypotension. Well, that's often what they're used for. Dizziness and syncope, the other word for fainting. And patients should be cautioned about what did I say? Patients should be cautioned about the risk of rebound hypertension if they abruptly stop taking the drug, because they block these beta receptors on the heart. The heart's saying, hey, I'm not getting enough beta activity. So it starts manufacturing more beta receptors. And but you don't see the effects of that because they're taking a drug that blocks all those beta receptors. And so if they suddenly quit taking it, now they've got a bajillion beta receptors that are exposed on their heart, very sensitive to sympathetic flow or sympathetic nervous activity. And so they're going to have this rebound phenomenon where their heart rate's going to go up and blood pressure is going to go up. And this makes them susceptible to myocardial infarction or heart attack. It's a serious condition related to receptor upregulation. So here's some of the main beta blockers from a historical view of beta blockers that characterize show some of the main features of beta blockers. Propranolol is the prototype. It's not specific for beta 1 or beta 2 receptors, so you would never give this drug to a patient with asthma. But it still has use. Pendolol is an example of a drug that contains intrinsic sympathomimetic activity, and that is that it's a partial agonist. Metoprolol is used as a cardioselective beta blocker, and that means it's specific for beta 1 receptors. And so if you hear the term cardioselective associated with a beta blocker, you know that that drug is specific for beta 1 receptors. Labetalol is another important drug that blocks both alpha and beta receptors, right? And I put in red type the A and B so that you can remember that, which drug blocks alpha and beta receptors, the one with the A and the B next to each other in the name. And and that becomes an important clinical feature. Also carvedilol is another drug that blocks both alpha and beta receptors. So the main effects of blocking beta receptors are on the heart, which causes the heart to beat slower. That is, it's negatively chronotropic. It causes the heartbeats to be softer, which is negative inotropic, right? And those are the two big cardiovascular effects. They cause a pronounced reduction in gluconeogenesis and glycogenolysis, right, which are necessary for compensating for hypoglycemia. They may block renin release, right, and some patients have hypertension that's related to excessive renin, and that is a beta 1 receptor mediated effect, and so they'll treat that. And they decrease intraocular pressure, which makes them important in the treatment of glaucoma. Okay. So propranolol is a prototype, not beta selective, but cardioselectivity, being beta-1 specific, is a term that you need to know. Metoprolol is associated with that. There is this thing of intrinsic sympathomimetic activity. You need to know that that's a feature of beta blockers, where the typical example is Pendolol. It's a partial agonist. So intrinsic sympathomimetic activity means the drug is a partial agonist, right? And it's used in patients that have excessive bradycardic reactions to propranolol. And some of your clinical faculty have told me that this is an outdated concept right here, but I'm going to include it, that some of the beta blockers have what's called membrane stabilizing activity. For example, acebutolol, which may improve cardiac arrhythmias. But they say that's not an important clinical feature, but it is a historical feature. These are just some of the examples shown here of beta blockers. And of this table, just some of the things that I point out is that esmolol, for example, has a really short half-life. This drug's trade name is Brevibloc. So if you needed to, like in the emergency room, you needed to block beta receptors for a very short period of time, esmolol would be a choice. The first drugs, acebutolol and atenolol, are both, and esmolol, all these drugs are cardioselective, as is metoprolol. Cardioselective, right? Beta-1 receptors. Labetalol is blocks, it's got this 2 superscript on it, which means that it blocks, it's got the 1 superscript on it, which means that it blocks beta-1, blocks beta and alpha receptors, as does this one right here, carvedilol. What else? So, intrinsic sympathomimetic activity, several of them do. I'm going to focus on Pendolol is doing that, right? So if you got that much out of this chart, you're doing good. All right. And just a reminder you might look at this just to sort of self-test to see how you're doing. These are flashcards, and there's, probably 1,000 sites on the internet that have flashcards for understanding autonomic pharmacology, because, as I mentioned previously, it's talked about in all pharmacology classes. And generally the same drugs and the same concepts are taught, all over medical schools, pharmacy schools, nursing schools, dental schools, vet schools, whatever. Everybody that takes pharmacology learns essentially the same thing, and these are pretty good for self-testing. And I think that's about all of it. It is. I hope you're doing well. I want you to make 100 on this test, but you're going to have to study, right? And I know you're going to be tired because this is your last exam, but I'm pulling for you. Do well, guys.